Hello, everyone. Good evening. Can everybody hear me loud and clear? Or good afternoon, depending on where you're calling from. Can you
Yes,
hear
we
me?
can. Yes,
All
we can
right.
hear you.
Excellent. Um, my name is Emmanuel. I'm one of the tutors in Essentium, and I'll be the one discussing with you today or moderating the tutorial. So I want to say welcome to the first tutorial session. Um, Hi, Adebola, welcome. I know Rashid as well. Hi, and Kubab, how are you doing? You can use either reaction or chat or even your voice and just say hello.
Thank you, sir.
Hi, welcome. Okay, so the first of all, I'll start the session by reminding you that we have a WhatsApp group for those that are not in the group. So you can reach out to us and we can add you. The topics I posted on the group, I know that some of us already have like a schedule that we're using to prepare for the exam. So that's fine. You can stick to your schedule. But the topics we're posting on the group are mostly for people that don't have, right, a personalized schedule. And that would be like a guide to, to help them prepare for the exam, to know what to do or what to do. And also, it's also for those of you that have your own schedule, you can also use the topics as a way to quickly review those topics that were posted to see if you're still strong in them or you have any concern that need to be addressed. Okay. So I am going to start by talking about, before going to the questions. So today will be question-based tutorial. We're going to be walking through a couple of questions together. And we'll be using UWord, QBank, right? Which a lot of you will be familiar with. No matter what the questions, some of the questions might even be familiar to you, but the goal here is to introduce to you some new test-taking skills or strategy that you may not have considered, right, before. The goal here is to see what you can pick up for yourself, right? What skills you can pick up, how you can modify your own skills, your exam approach, see if there's anything new you can incorporate, right, into your study strategy. Also, the goal here will be to clarify some concepts that are not very, very clear. So as we go through these questions, I want you to take notes. If you have questions immediately after each question we attempt together, you can ask them immediately. If you want to write the questions down or as we go on, as questions come to you, and you don't want to disrupt the class, you can write them down. And towards the end of the class, there will be we're going to free up some time to go through any questions you may have, but also during the session, if I ask if there's any question after each question we go through, feel free to ask your questions immediately. But ultimately, make sure you're picking up new things. Make sure you're paying attention to new skills. See if there's a way you can make your own approach better, what you can modify, and things like that. So but before we go into the questions, I want to first of all address how do you get started, right, with the USMLE preparation. So for those of us that are, for the benefit of those of us that have not started fully, or they are still trying to weigh their options, the first thing I want you to do is to go to the USMLE official website and read about the exam, right? That's going to be very, very important. You want to understand what is required of you, what the examiner wants you to, what the step one is all about, what they're testing, or what step two is about, what step three is about, depending on the exam you're taking. Assuming most of us here are taking step one, actually. So you want to know what the exam is about, what they're testing, what the content area is, things like that. So the best way, the best source will be the official website of the USMLE, right? USMLE.org. So always start there, okay? Then the second thing is that before you start your prep, I will always encourage you to take an assessment first. Take an assessment. This is for people that are just starting, right? You don't know how to start, where to start, right? Start with the USMLE website, read about the exam in detail, and understand what it's saying, what is expected of you. And then secondly, do an assessment, right? Remember that this journey has to be intentional. You cannot be guessing. Am I ready? Am I not ready? Am I making progress? Are the things I'm doing working or not? You cannot leave room for guessing. So the best way to know objectively if you are progressing the way you should, if whatever you'll be doing when you're studying is working, is through assessment, right? And please don't use your NBME as a Q bank, right? Don't go through NBME forms offline. You are minimizing their use. You're not maximizing them. Make sure you try and actually buy the form online and take the timed exam. So you can use NBME, you can use RX assessment, you can use Kaplan assessment. Kaplan has a free assessment. You can take a free assessment to see where you are. The goal is to know where you're starting from. What is my score now? What subject am I struggling with now? Because nobody's starting from scratch. We know some things. You may have some strengths from med school. You may have some weaknesses. You will not know objectively without an assessment. So when you take an assessment first, you will now start studying, right? So, and the goal is to start with the weakest and work your way to the strongest. So the best way to improve my score on USMLE exam preparation is to strengthen my weaknesses. It's not by focusing on your strength. So if you know that biochemistry is a weakness, where you are getting maybe 70% average in other subjects, you know that biochemistry usually get 30% average, 20% average. Please don't ignore it and still focus on pathology and physio alone. You have to drag that biochemistry up because you want to drag it up. Even if you drag it up to at least 50%, 60% average, you will see that that will have a better or the most impact on your overall score, right? Than working only on your strength, right? If I'm already getting 80% in a subject, what is the maximum I can increase it to? Maybe 90, probably 95, right? But ideally not 100 in most cases. But if I'm getting 20% in a subject, then you can see the potential of increments, right? Is almost 50 times, 50%, like twice what I would have done, 3 times what I would have done, right? With the strong subject. So never ever ignore your weaknesses. So after you take your first assessment and you see what it says and you see which areas are really, really bad, start with those areas first. Try to drag them up as much as possible, and then you can now work your way to the strength. And you can take regular assessment to compare with the previous one to see if you're making progress, right? And you can always adjust accordingly. So this is a quick advice for those that are just getting started with the exam and they really don't know where to start or what to do. So read about the exam first on the USMLE website, official website. You can, and then you do your first assessment, which can be RX, USMLE. Kaplan has a free assessment, UWard rather assessment. NBME will be the best and recommended one. And Kaplan has a free assessment as well if you don't want to buy one. And you take that and see where you stand and then start with your weakest area with recommended resources and then work your way towards the strength. And then you keep evaluating yourself over time, right? To compare, right? And see if you're making progress. So that's for those that are getting started. For those that already started their preparation, also assessment will be important to you. Please don't study for 6 months before taking assessment. That is not a good idea. You want to take assessment as often as every 1 month to every 2 months, depending on how quickly or how much time you have, right, to study, because that would be the best way to know if whatever you are doing is working or it's not working, right? And don't hesitate to reevaluate or change your strategy as you are, or to change your strategy. As you're identifying new areas of weaknesses, make sure you prioritize them. Don't feel comfortable, right, with only sticking to things you know. The ones that you are weak at, those are the best chances of improving your overall score, right, on the exam, all right? So that's just a brief um, topic I want to talk about first today before we go into the tutorial, right, session. If you have any questions on how to get started, please, you can post it on the WhatsApp group, and I will elaborate more, right, on that. Okay, so let's start with the question, the crux of today's tutorial, right, meeting. One more thing I want to emphasize before we start going through the questions. So we're using UWard QBank. I have 10 questions pulled up, and they're based on the topics we posted today, right? This week, right? And throughout this week, which are the general principles, general pathology, general pharm, the cell biology, molecular biology, physiology and membrane physiology, etc. So they are based on that. And the idea is just to go through those questions to reinforce those concepts, make sure you understand them, explain or clarify things that are not so clear, and also give you a chance to start seeing what some test-taking skills that may be very, very helpful that you might incorporate into your own study and see if it can make your study more efficient. So I am sharing my screen now. And if you cannot see my screen, please just let me know either in the chat or you can tell me if you cannot see my screen. All right. So I assume everybody can see my screen.
So one person says can't see their screen. I don't know. Kubab?
You cannot see my screen?
No, Kubab said that he cannot
I
see your
can't
screen.
see your screen.
I think everyone can see now.
Okay. Kubab, can you see
I
my
can't
screen?
see the screen. Yeah. No. I can't see.
You can see it now.
Yeah.
Kubab, I want to be sure I
I
get you
don't
right.
know why.
You cannot see it. You cannot see it.
I cannot see. I cannot see your screen.
Hmm. And I think you might be the only one. Okay, let me
So
reshare with
let
you.
Kubab let him log out. Can you log out and log in again? Let's see if the
All
same
right.
is himself.
Okay. I will log out and log in again.
All
Yeah,
right.
that'll be
Excellent.
nice. Okay, thank you.
Okay. So here's our first question, and there are so many approaches, right, to doing questions for the USMLE exam. I'm sure a lot of you would have seen that the exam is a little bit different from maybe other professional exams, or a lot different. You have long vignettes, they describe patients, you have a question, and you have a bunch of options, right, to choose from. And another thing is the exam test understanding at every level as much as possible. So that's something else to keep in mind. And there are so many ways to approach the questions. You can have different approaches like in my many years of tutoring people, I've seen different approaches like some students can start from the top, from the beginning, read the whole vignette, go through the option and try to pick an answer, right? You also have approaches where you can start from the question here, right? And you read the options, right? You read the question first and then you go to the options. Sorry, you read the question first, you go to the vignette, then you come back to your answer, or you read the question first and the options, and then you go to the vignette and you pick an answer, right? So different approaches. I'm actually curious. I want to see which ones you use personally. I want to see which one we use. So in the chat, if you can type which approach you use for questions. You start from the beginning for your some questions. You start from the beginning and you read the whole thing from the beginning to the end. Do you start with the question first, the last question first, and the options, and then you go through the vignette? I'm just curious. I want to see, please quickly type in the chat and let me know what approach you normally use for your questions from the beginning, or you start with a question from the beginning of the vignette, or you start with a question first. Right. So the lock says from the last question and then works his way, right, to the beginning. Okay, Mahmoud says mix of both, but recently started from the end more. Adebola started initially from the beginning, but now start with question. Okay, K says options, last question, then beginning. Okay, so start with the option first, then question. Okay, excellent. All right, I see that the approach that is most common for almost everybody is starting from the question and then working the way to the beginning. Oge says she breezed through the question, through the answer options, and then what brought them and the last question. Okay, last question and options. Okay, so the last question, options, and then the vignette, right, seems to be the most popular approach. Personally, I would advocate for going through the question first, right? Going through the questions and the options first, or going through the questions alone first before you go to the vignette, right? When I go through a question at the end, the first thing I want to, so this is our question here. What is the objective? I want to find out why. What does the examiner want you to do? So the objective of going through the question first is to find out why you're given this vignette. You want to figure out the objective of this question before you even say it. Why does the examiner want me to go through this vignette? What does it want me to do? What does the examiner expect from you? Also, what am I looking for? Right? What am I looking for in the vignette? What should I look for in the vignette to get me to the answer? So that is why going through the question will be very important, because it gives you purpose. It gives you purpose for that vignette. You're not going to be reading the vignette aimlessly. Vignettes are so long, they have so many information. How will I know what to pay attention to? How will I know what is most important? How will I not get distracted? I want to read the question first and possibly the options as well, but that's not mandatory. And the goal you're asking, when you read the question, you're just asking yourself, what does the examiner want me to do here? What is the purpose? What am I looking for in the vignette to pick the correct answer? Things like that. So that way you are going to the vignette with purpose, right? Not blindly. So in this case, the question we have says, which of the following best explains the use of this adjusted parameter? Which of the following best explains the use of this adjusted parameter? So which of the following best explains? So the options you are given are options that explain something. What are they explaining? The use of the adjusted parameter. So in the vignette, what am I looking for in the vignette? I'm looking for whatever adjusted parameter we're given. We don't know what that adjusted parameter is yet. So that's what I need to find. That's my blind spot for this vignette, right? I don't know what the adjusted parameter is, but when I find, so my first step will be what? Find the adjusted parameter that the examiner is referring to. And then I have to choose from the option what explains the use of that, right? Adjusted parameter. But I must find that parameter first. After I find the parameter, I can now answer the question. I can explain it. I'll try to explain it, why it's done. So the explanation is in the options, but what am I looking for that we don't know yet? It is the adjusted parameter, all right? This is what we're looking for in the vignette. So now let's go to the vignette. We have a purpose. We know what we're hunting for, literally, right? What we're looking for. So we're going to go to the vignette and find that adjusted parameter. So we're given, when you're going through vignette as well, there are different sections of a vignette. You have objective part of the vignette. You have subjective. Subjective will be what the patient says, their complaint, and then you have objective findings, typically physical examination, labs, etc., right? And if you notice or you have observed, most of the distractors are in the what and in the subjective findings. Whatever the patient tells us, they are past what they've been doing before, that's where they might put one distractor or the other. But the most trusted information are usually what? Are usually the objective findings, right? So that's one thing. Another thing I want to take note of here is that whenever an examiner uses the word these, right? These adjusted parameter here, these, whatever the parameter is or whatever you're looking for is before the question, typically immediately before. Oh, which of the following best explains these symptoms? This medication, this, this X, this Y. Look for that information just before that question. So that way, even if the vignette is this long, I don't have to read everything. I can start first by looking at the sentence before the question. So in this case, since I see the word this here, I start thinking, oh, what is this parameter could be before the question. So let's see. The sentence before the question says, while calculating the appropriate dosage, the hospital pharmacy uses an adjusted body weight that is lower than the patient's actual body weight. So from that sentence, I actually know the parameter. What is the adjusted parameter? It is the word body weight. So when the pharmacy was calculating the dosage of something, of a medication, they use the adjusted body weight, which is lower than the patient's actual body weight. That's the adjusted parameter. So the examiner is asking me indirectly, explain why, when calculating the dose of a medication, we are using a weight, a weight of the patient that is lower than the patient's actual body weight. That's what the examiner wants me to figure out. Why will I use a lower body weight to calculate the dose of a medication? And you can see that I found that parameter just before the question because of this word this. So I've probably saved myself time, right? Reading this whole thing, which I don't need to, or I might not need to, okay? So based on this, right? Why do we use, what is the importance of weight, body weight in calculating dosage of medication? So this concept is pharmacology. We know from the question. This is testing us on general principles of pharmacology. We're calculating dose and they're mentioning body weight. But the question is, why is it important? Number one. Number two, I want to figure out, can we pick an answer without reading the whole vignette? Based on these last two sentences we have, while calculating the dosage, they use a lower body weight than the patient's actual body weight. And the question is why? Can we figure it out? Why we're using a lower body weight to calculate the dose of a medication without reading the vignette? Can anybody try? And you can use your audio. You can use your audio to explain if you want to. If you want to type, you can type. I think audio will be faster for us. Can we figure out what you think the answer could be without reading the whole vignette? Let's try. Wants to try. Why will I use a lower dose of medication, a lower weight to calculate the dosage of medication? What property of a medication can we predict with the weight, with body weight? What property of medications can we directly predict from body weight? Why do we give people with different weight, different dose of a medication? Why can't we give everybody the same dose? Just regardless of the weight. Volume of distribution, right? So Rashid is right. If this question is asking about dose, and I want to link it back to my pharmacodynamics, right? My dose depends on what? It depends on VD times CPSS. That's what determines our dose. Although maintenance dose is different, but this is like a loading dose, right? They want to give a dose, the first dose of the medication. It depends on volume of distribution and the steady state plasma concentration. Why can't I give everybody the same dose of a medication? Because everybody have different volume of distribution. Volume meaning the volume the drug will occupy, right, in the body of everybody will be different. And the volume of water we have in our body depends on what? Our weight. And of course, gender, right? Right? Depends on our weight. Patients that are bigger have higher volume of water. Patients that are smaller will have lower, right, volume of water. So if I give people with different weights the same dose of a medication, what will happen? The person with a higher volume will dilute the drug more, and you may not achieve what? That concentration you want to achieve. While the person with a lower volume, the drug will be more concentrated and can actually lead to toxicity because they have less volume. So the drug doesn't occupy a lot. It's not diluted as much. So it stays more at a higher concentration. And that's why we depend on the weight. So the weight will tell me, it's indirectly telling me about the volume of distribution of that individual. And people that have higher volume will require higher dose for us to still maintain, right, or achieve the same concentration in the blood of that drug. All right? Yeah. So why will I use a lower body weight to calculate a dose in a patient? I want to give a patient medication. Why will I use a lower body weight? Because of what? That drug likely has what? The drug likely has a lower volume of distribution. That's why I use a lower weight. If the drug has a lower volume of distribution, doesn't occupy a lot of space in the body, I want to give a lower dose. So I'll use a lower weight of the patient, right? If the drug has a large volume of distribution, goes everywhere in the body, I might even use a weight that is higher than the person's actual weight so that I will give a higher dose, right? To adjust for that increased volume or account for the increased volume of distribution. So this is the link here. The calculating a dose, we're using weight. Why do we need weight to calculate dose? Because of volume of distribution. Weight tells us about the person's individual's VD. So I need to adjust or account for that VD, right? To still be able to achieve the same concentration of the drug, right? In everybody. So people with higher VD, higher weight will require higher dose naturally. People with lower weight, lower VD will require lower dose to still achieve the same concentration. So this question is asking, why would they use a lower body weight of the patient than the actual body weight to calculate the dose? It has to be because what this drug, whatever this drug is, occupies what? A lower VD. Because if it occupies a higher VD, I will not decrease the weight. I will use the actual weight or use even a higher weight to calculate the dose. So our best answer based on my explanation would be what? Our best answer would be, best answer is going to be, it's going to be A, right? It's going to be A. It's going to be A, right? Yes. So see how what is the concept that this is the concept, right? But USMLE will never come and tell you, ask you, what is VD? What is the parameter that determines VD? How do you calculate those? They will never ask you that, ever. Instead, they'll design a scenario that will still take you back. So I want you to start practicing this from now. Anytime you see a USMLE question, ask yourself, what principle, what concept is this question testing? Find that concept. What graph, what formula, what pattern fees? You must find it. Link it to something. And that's the goal. So that if they bring another question, not like this in your USMLE exam, right? That is also testing relationship between dose and weight and VD. They will not ask like this. They may ask another way, but you know that this formula will come back to you and be like, oh, I remember this. And you still get that question correctly. You go to another cube and amboss, and you see another question testing relationship between dose and VD and LD and weight. They will bring it another way, right? But you'll link it back to this formula again and you still get it right. So A should be our best here, right? Distribution of the drug, okay? Any question before we move to the next one? Any question on this? Okay, excellent. Now let's see the next one. So two is, we're still gonna use the approach we used in the first one. We start with the question first. We wanna figure out what is the purpose of this question, and then we dive in, all right? So here, we have our question here starting here. Says, which of the following is the best explanation for these? Which of the following is the best explanation for this? Best explanation for this, for something. So which means that what? Our options are what? A bunch of explanation, things that will explain. Our options include things that will explain something. Whatever it is, we don't know yet, right? We'll find out. That's what we need to find out in the vignette. We need to find out what this is in the vignette. But our options are what? Explanations for something. If I quickly glance through my options, look at the options we have. Allelic heterogeneity, heteroplasmy, incomplete penetrance, linkage equilibrium, locus heterogeneity, pleiotropy. These are what? Genetic principles. So this question is about what? Testing us, it's about genetics. This is a genetics question. These are genetic principles. It's testing us on a basic genetic principle. Now, when you get a question like this, right, it is very, very important that you understand all the terminologies you have in the options. I didn't say memorize. I didn't say you should be able to regurgitate. You should understand them. Because when I understand these, right, these options, I already know, I put myself in the examiner's brain and mind, and I can predict what kind of vignette will test each one. So when I see what looks like them or what is testing them, I'll pick the answer quickly without being confused. So your first objective is to be able to understand these terms. When you have terms like this, understanding, not be able to define them, but you must be able to understand them. All right. One of the first things I want you guys to do, right, for genetic principle is ask yourself, what genetic disorders do they apply to? That is number one step. What kind of genetic disorder do they apply to? Do they apply to autosomal recessive, autosomal dominant, X-linked, mitochondrial, etc.? That's your first objective. If you know that, that may be, you may even get the answer with that alone, without even knowing the detail of that principle. So for instance, allelic heterogeneity applies to what? Autosomal recessive disorder. Locus heterogeneity applies to autosomal recessive disorders, right? Heteroplasmy applies to mitochondrial disorders. Incomplete penetrance applies to autosomal dominant disorders. Pleiotropy applies to single gene disorders, like not microsomal disorders, not chromosomal disorders, single gene. So it won't apply to things like Down syndrome. Those are chromosomal issues, right? Pleiotropy will apply to single gene disorders, right? Single gene, where there's a single gene mutation. It can be autosomal recessive, dominant, etc., right? Anyone, but mostly also dominant typically, but it can be recessive. But I like just think of it as single gene, doesn't apply to chromosome. Linkage disequilibrium is a population issue, population genetics, right? Population genetics. That's what it is, linkage disequilibrium. So this is like your first step. Take the genetic principles, link them to the kind of disorder they apply to. So in my first objective of going through the vignette is to figure out, is the disorder, whatever this is it autosomal recessive, dominant, mitochondria, is it population genetics, single gene, chromosomal, whatever. If I figure that out, I can narrow down my options at the very least. I even pick an answer and you're done. Now, the second layer to build on will be what? Once I know the disorder it applies to, I should be able to understand, especially the ones that apply to what? Multiple disorders. Let me give you an example. If this vignette is a mitochondrial disorder, right? The only answer will be B, because there is no other mitochondrial disorder principle in the option. If this vignette is an autosomal dominant disorder, the only answer it would be C, because there's no other autosomal dominant principle in the option. If this question was about population genetics, the only answer is going to be D, because there's no other population genetics principle in the vignette, in the option. But if the vignette is autosomal recessive, I now have to decide between A and E at the very least, because I have at least two principles, right, in the option for autosomal recessive. So that will make my life a little bit difficult, but at least I would have narrowed down the options to 2 options out of 6. So that's why it's important to know what pattern. That's your first job. Now, the only one that if I know the pattern of disorder it applies to, for A and E now, I need to be able to differentiate them from each other, right? That will be my next layer. I need to now understand them, what they mean, what's the difference, right? For A, for instance, okay, let us first of all apply the first principle. Let's apply the first principle and see if we need to differentiate them, right, to pick an answer. Let's apply the first principle. So this says for these, right? So, like I said before, whenever you see the examiner uses the word these, check for the information you're looking for before the question first. So see if you don't need to read the whole thing. So here they said that the couple asks about their chance of having a child with oculocutaneous albinism. Bim, 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 right? So the disease is what? Albinism. My question is, what is the pattern of inheritance of albinism, guys? Is it AR, mitochondria, AD? Is it AR?
Recessive.
Yeah, autosomal recessive. So that narrows down our options automatically to what? Narrows it down quickly. Based on that, we can rule out everything. But I'll leave F as well. We can rule out everything except A and E for sure, but I'll also leave F because albinism is also a single gene disorder, right? It can be a single gene disorder, although it is not, though. It is not a single gene disorder. I will explain. It is not a single gene disorder, so I'll rule out F as well. It can affect multiple genes, several genes, right? It's not a single gene disorder, right? It can affect several genes. So I'll leave A and E. I'll leave A and E. Those are principles that apply to only autosomal recessive. They don't apply to any other, right? Disorder, okay? So that's important. Now we need to differentiate them from each other. And let's see. So I need to explain what they mean quickly, and then you now go to the vignette and figure out exactly what is going on. So look at this. Allelic heterogeneity means different, right? The word heterogeneity means different, not the same, hetero. What is different in allelic? The alleles are different. Alleles are what? Different variants of the same gene. So same gene, same location, but they're slightly different. What that means is that if I have 5 people with albinism, right? If I have 5 people with albinism, that is on the, and the mutation is on the same allele, the same location, same gene. So let's say, for instance, it's on chromosome 5p. 5 people with albinism, they all have mutation on chromosome 5p, but the mutations are different. It's not the same mutation. It's the same location, 5p, but mutations are different, meaning one of them have single gene deletion. Another one has point mutation. Another one has frame shift mutation. Another one has substitution, right? So that would be an example of allelic heterogeneity. The genes are on the same location, on the same chromosome, but the mutation affecting them is what? Is different. So the difference is the mutation. This heterogeneity is the mutation that is different, but the alleles just means that they are on the same location. Alleles are the same genes on the same location. They're just slightly different from each other. So what is different in allelic could be what the mutation is different. One of them have frame shift. One of them have point. One of them have this. One of them have that. That's what is different. Now for E, the location is what is different. Also heterogeneity, different, but what is different is the locus, location. So what is different in E is the location that is different. That is different genes. This is when people with different gene mutation, right, have the same disorder. Yes, Kubab. Look, for allele heterogeneity, the location is the same, excellent, but the alleles are different, right? They have different mutation, excellent, same location. But in locus heterogeneity, location is different, although the mutation can be the same. Mutation can be the same, but the location is different. This means that if I have 5 people with albinism, if I gather 5 people with albinism, the first person can have mutation on chromosome 5p. The second person will have mutation on chromosome 7p. The next one will have mutation on chromosome 10q. The next one will have mutation on chromosome 12p, right? So different locations, but guess what? They have the same disorder. Which means multiple genes, right, are important for melanin production. Okay? So if any of those genes are affected, patient will still develop the same disorder, but they are on different location. But for allelic heterogeneity is the same location, but different mutation. All right. So how will an examiner test what we just explained? Because nobody will ask you, define allelic heterogeneity, right? You have to test it. How will I know if they're testing A or E? Now, let's take A first. In A, if people have the same, if they have different mutations affecting the same gene, how will they manifest? They will manifest differently. What that means is that the person with deletion mutation, frame shift mutation, which is a terrible, is the worst kind of mutation, right? They will have what? Worse symptoms and signs, right, than other people. That's what I mean. You are looking at the severity. That's how you determine this. People with the same disorder, but they have different severity. So if take cystic fibrosis, AR, you can see that some people with cystic fibrosis will have what? They will not survive childhood. Some patients with cystic fibrosis, they will survive childhood, right? But they have recurrent infection throughout their life. Some people with cystic fibrosis will not even have any symptoms. You won't know they have it. They're not symptomatic. Some people with cystic fibrosis will only have maybe pneumonia, nothing like that. They are fertile. Some people with cystic fibrosis will have infertility, but they don't have any other thing. Why do people with the same condition, they have the same cystic fibrosis, same gene, same location, but they have different manifestation or different severity? Is because they have different mutations at that gene. That would be an example of allelic heterogeneity. people with the same autosomal recessive disorder on the same gene, same location, but they are manifesting the disease differently. You are thinking option A. They have different mutations. Some people have severe mutations like deletion. Some people have like a silent mutation, a point mutation, or something which is milder. That is A. But how would an examiner test E? An examiner will test E by telling you that, remember, normally, right? Normally, let me build on what you already know. If I have two parents, guys, two parents with an autosomal recessive disorder, two parents with autosomal recessive disorder, what is the chance that their children will have the disease? If two parents have autosomal recessive disorder, what will be the chance that their children will have that disease? What do you think? Two parents. Just put a percentage in the chat. If two parents have autosomal recessive disorder, what will be the chance that their children, based on our the crossing, right? What will be the chance? It's going to be 100% normally. Look at this. Two parents with autosomal recessive, they'll both have what? Small a, right? Small a. If two parents have an autosomal recessive disorder on the same gene, the chance that all their children will have disease will be 100%. All of them will have it. All of them. It's going to be 100%. 100%. Two parents with autosomal recessive disorder, they will have 100% chance of having children with that same disorder. Because both parents have what? Small a. If I cross the genes, all the children will have what? Small a. 100%. Because the mutation is where? Is on the same gene. Is on the same location. So both parents, if it's on chromosome 1, both parents have what? All their copies of chromosome 1 will be mutated. So they will pass all the mutated chromosome 1 to their children, and all the children will also have the disease. But if an autosomal recessive disorder is a disorder that affects what? Different genes, then you find out that what? The children will have 0 chance of having the disease. If it's an autosomal disorder that affects different genes, the chance of the children having disease will be what? Will be 0%. Why? Let's say if the father has albinism because of what? Because chromosome 1 mutation. Chromosome 1 mutation. So the father has 2 mutated chromosome 1. That's why the father has albinism. The mother had albinism because of what? She had chromosome 10 mutation. 10 mutation, right? Different location of the mutation. What will happen to them when they have children? The father will give the children the mutated chromosome 1, but the mother will give them what? The normal chromosome 1. So they can't develop the disease because it's recessive. The mother will give the children mutated chromosome 10, but the father will give them the normal chromosome 10. And that creates what? Heterozygosity, right? So they won't develop the disease. So when you start suspecting E is when you have parents with parents with the same autosomal recessive disorder, but their children do not have the disease at all. Those parents have what? Mutations on different locations, and they are complementing each other, right? So all their children will be what? Completely asymptomatic, right? They're going to be asymptomatic, all right? So that is what E means, right? That is what E means, low-cost heterogeneity. So let's go back to our vignette now and quickly see, right, what we're dealing with. We know this autosomal recessive disorder. We narrow down to A and E, but let's see what they told us. The couple asked, right, about their chance of having a child with oculocutaneous albinism, and they are told that what? It's 0%. The doctor is telling them that even though you have autosomal recessive disorder, both of you have autosomal recessive disorder. The husband has it on chromosome 11. The wife has it on chromosome 15. But the doctor is telling them that their chance of having a child with the mutation is what? With the disease is 0%, meaning that they will complement each other. If the mother gives the children this mutation, the father has a normal chromosome 15q12, q13. So they will not develop the disease. If the husband gives the children mutated 11q14.3, the mother will give them the normal copy, and they're going to complement each other, and the children will never develop the disease. They'll just be carriers of the mutations, but they will never manifest the disease. And this is what? Due to locus heterogeneity. The mutation is on different location. Is everybody still with me? In the chat, type you're still with me, please. Everybody, if you're still with me, if I haven't lost you, in the chat, say you're still with us.
Sir,
Go ahead, Kubab.
sir, it's mean the allelic heterogeneity mutations, there will be severe symptoms, and locus heterogeneity, there will be like just mutation, but they will just be a carrier, means that there will be no symptoms in the children.
Right, so local heterogeneity, right, will explain why two parents with an autosomal recessive disorder will not have children with the disorder.
So it's mean they are just carrier.
The children will be carriers, but they will not manifest the disease because they will be heterozygous.
Yeah, so what will be the best option here?
Huh?
What will be the best option here?
It's going to be E. We have two
Oh,
parents with albinism, but their chance
yeah,
of having a
different
child,
chromosome. Yeah, different chromosome.
right, on different chromosome, yeah. So that's
Oh, thank you,
locus,
sir.
different
Thank you,
location,
sir.
right?
Thank you, sir.
Yes,
Thank you, sir.
yes, different location. So their chance of having a child with you will be 0%. Yeah, different location. Right, let's see the next one. So this says, which of the following is the best response to So this next one is asking us, which of the following is the best response to their concerns? Which of the following is the best response to their concerns? So best response will be in the option, right? I want to tell whatever the want to address, right? Basically the concern. And the options are related to condition is not hereditary, child's biological sex, mother's characteristics, probability, right? So this also looks like genetics question, was genetics probability, right? So what we don't know that we need to figure out is what the concerns, right? Which are the following is the best response to their concerns. So we want to figure out what the concerns are, and then we'll now be able to pick, right, the best response to that concern. So let's see what the concerns are for the couple, right? So here we have a married couple comes to the office for routine prenatal counseling. The husband is 120 centimeters tall with disproportionately short upper and lower extremities, a large head, and a prominent forehead. He cannot provide a biological family history because he was adopted. His spouse is average height with no dysmorphic features and a family history is insignificant. They inquire about the likelihood that their offspring will have short stature due to the same condition. So their concern is that what is the likelihood or probability that their offspring will have short stature due to the same condition the father has? The chance that their offspring will have a short stature due to the same condition, right? The father has. So our first objective would be what? What condition does the father have? First question, right? Two, if I know the condition, I need to figure out what the inheritance pattern of that condition. And three, I will now answer the question, address the couple's concerns, right? So first will be what is the condition? What is the inheritance pattern of that condition? Then we can now properly address, right, the couple's concern. So my first question is, what is the condition? What do you think? What is the condition? The clue to the condition is to the father, right? Is the description of the husband, right? So what is the condition? Based on the husband's description, what condition are we dealing with here? Good. Oge says achondroplasia. Excellent. So is there any objection to that? If there's any objection to that, you can type it in the option in the chat if you have an objection. So achondroplasia, okay. Kubab agrees. All right, I also agree, right? Achondroplasia. The husband is short, 120 centimeters, that's 3 feet 11 inches. But what is key here? How do we know this is definitely achondroplasia and not just, short stature? Is that the extremities are short compared to the what? The extremities are short compared to the forehead, the head, right? The extremities are short. So the upper and lower extremities are short, but typically in albinism, you see that the trunk is usually of normal size. The head will appear bigger, but actually it's normal size head, but because the extremities are short, their head appears bigger than usual, and they'll have this prominent forehead and all that. So this is definitely achondroplasia. What is the inheritance pattern of achondroplasia? Step 2, inheritance pattern of achondroplasia is autosomal dominant. Excellent. AD, autosomal dominant. Autosomal dominant. Excellent. So what option will address the couple's concern? If the condition is autosomal dominant and we've ascertained that the husband has the wife, they describe that she has no dysmorphic features, no family history, what option will address the concern that their child will have achondroplasia? Okay, I see E, 50%. All right, 50%, right? 50%. Excellent. So, 50%. E, right? Now, I want to dig deeper a little bit. Now, I want to ask you guys a question. A little bit. So the answer is correct. It's going to be E, right? But let's go back to the beginning of this vignette, right? And I want to give you some scenarios and see. This same question, something similar, like you have the same options, right? Same option, we're not changing the options. But you get a similar question in the USMLE exam, on your exam or NBME exam, right? And the condition you are given, you don't know the condition. Like they describe the husband, and the husband, you cannot figure it out. Based on this presentation, the signs and symptoms you're giving, you cannot figure out what the husband has. You can't figure it out. Maybe it's an experimental condition. Maybe it's a condition that you've never seen before. It's very rare, right? So you can't figure it out. You don't know what the condition is. So if you don't know the condition, you cannot know the inheritance, right? Does that mean that I'm good? And if I don't know the inheritance, I cannot figure out the answer. Does that mean I'm going to fail the question? The answer will be no. So I want to ask you guys, let's say we don't know the condition based on the description of the husband. Can I still figure out this is autosomal dominant? And if the answer is yes, how? If we don't know that this is autosomal dominant, can we still, we don't know that it's achondroplasia. Can we still figure out that it's autosomal dominant? If yes, how? Don't know it's autosomal dominant, it's achondroplasia. Can I still figure out it's autosomal dominant? If I don't know if I don't know the conditions of achondroplasia, can I still figure out step 2? Can I still figure out the inheritance pattern? If I don't know it's achondroplasia. Okay, so okay says possibly, right? So what I'm saying is that this description of the husband, if you don't know what it is, so the reason we're able to go all the way quickly to go through steps 1, 2, 3 is because we know step 1, right? We know what the condition is, achondroplasia. Then from there easily AD, from there can address the concern. But I'm saying that you might get a question where you don't know the condition because they didn't describe it properly, or it's a rare disorder and you have no idea what it is. Can I still figure out step 2? Can I still know the inheritance pattern or I cannot? Okay, so possibly I can, but remember that it's not that simple. It's not that simple because the husband has the condition and the wife doesn't, right? It's going to be difficult. The examiner has to give you more information. They have to give you more information. If that is the route the examiner wants to go through, for you to determine the inheritance without knowing the condition, you're going to be given the family history of the husband. Because if the husband has it and the wife doesn't, I don't know if it's AD. It could be autosomal recessive. It could be X-linked recessive because men have X-linked recessive, right? But women don't. They are not symptomatic. So I can't tell if I don't know the condition. All right. So in that scenario, the examiner will give you more information. The examiner could give you more information. Otherwise, you're just going to be guessing. Possibilities will be a lot. All right, so they cannot tell you about the families, the husband's family, tell you that the parents also have the condition, or one of the parents have the condition, or none of the parents have it, and then you can start piecing it together that, oh, this could be dominant or recessive, right? Mutation, all right? So the reason I'm asking that is because I don't want you to ever think that you don't have enough information to pick an answer in the vignette, right? So the examiner will give you enough information to make the right choice. Use the information you have to the best of your ability. So don't ever think that this is confusing because I don't have enough information. No, even if you're given 2 sentences, figure out the answer based on that. All right. Yeah. So, but they will never give you a scenario where you have to be guessing. You're not going to be given a question that is not clear. Right. So make sure you don't give up on questions because you think that we don't have enough information, or you're going to get an option that says that you cannot determine, right? The risk, right? Or you need more information or something like that in the option, I can go with that. All right. But this is very good, straightforward. Work condition, inheritance, and then you have your consent, which will be E. All right. Very good. Any question on this?
Sir,
Go ahead.
sir, can you just give a short difference between the autosomal recessive and dominant? Some of my teacher told me that if you want to decide the recessive condition, so it's mean that they need totally problem from mother as well as from father. But in dominant cases, the case will be is like maybe the father have the problem, the mother does not have the problem, but the condition will be like transfer from father to the child is like 50%.
Right. So dominant mutations are mutations that manifest in the presence of a normal gene, right? Remember, we have 2 copies of every gene. We have 2 copies of every gene. We have 2 alleles, right?
Yes.
So a dominant mutation is a mutation that will still manifest itself, even if a patient has a normal gene. So which means we only need 1 copy. On autosomal dominant disorder to manifest itself, patient only needs 1 copy of that mutation, not 2. And that is why
Okay.
they only need one. That's why if it's a dominant, only one parent will also have the disease.
So it's mean that dominant need 1 copy and recessive need 2 copies.
Right. A
Okay.
patient must acquire 2 copies of the mutation. So both genes, both alleles must be mutated, right, before a recessive mutation manifests itself. If a
Okay.
patient
Thank
has
you,
only
sir.
1 copy of a recessive mutation, they are carriers, but they will not manifest, right, the disease.
Okay. Okay. Thank you, sir.
But for dominant, at least one is necessary. That's why if you notice the parents of people with dominant mutations, one of the parents also has the disease because it's a dominant
Okay.
mutation. Right. The one of the parents also will carry the mutation and also manifest the disease and pass that mutation to the children. But for recessive disorders, people with autosomal recessive disorders, they may have both parents without symptoms, but both of them will be carriers. They are carrying the mutation, but they don't have symptoms because they only carry 1 copy each, and they'll
Oh,
pass 1 copy to the one copy to each to the child, and then the child will have 2 copies, and only the child will be symptomatic in that case.
that's me that recessive. Yeah. Thank you so much, sir, for such a great explanation. Thank you.
Right. Okay. Let's do one more before we go. So this says a mutation in which of the following genes is most likely responsible for this patient's condition, right? Mutation in which of the following genes. So there is a mutation from the question. We have to identify the gene with the mutation. And then what we're going to use the mutation we're looking for. Ella, the condition we just saw is autosomal dominant, right? Achondroplasia, it is dominant, right? Dominant. So the mutation, so the options we're given are a bunch of list of genes that's mutated, and the patient has a condition, right? So what I don't know yet is what the condition. I need to figure out what the condition is, right? And then I will figure out which gene mutation will cause That's condition, right? I need to figure out what the condition is and then figure out which gene is causing the condition. So what is the patient's condition? So we have and this is also another option where, look at this patient's condition. If I want to go backwards, I can quickly figure out what the condition is. And the sentence before the question says, biopsy of the mass reviews, right? Adenocarcinoma. But that's not enough for us. We need to figure out what kind of adenocarcinoma. We need to figure out what it is, etc., where it is, right? So we cannot take a shortcut here. We have to read more, right? Information, read more vignette. So we have a 38-year-old man has a bloody stool, weight loss, and anemia. And the patient is young and has the symptoms. Bloody stool, we already know it's cancer we're dealing with. And if a patient with cancer has bloody stools, weight loss, anemia, where is the cancer? Likely the GIT, right, in the colon. Doesn't have any past medical history, does not take any medications, alcohol, drinks, doesn't drink, doesn't use alcohol, sorry, drinks socially. They told us about the father. Father died of colon cancer at the age of 40. Younger sister suffers from endometrial cancer. Exam is remarkable for minimal right-sided abdominal tenderness without getting to deep palpation. There's blood in the stool. Colonoscopy shows a right-sided ulcerative colon mass. No polyps are seen. Biopsy of the mass reveals adenocarcinoma. All right. So what mutation does the patient have? What mutation does the patient have? My first question is that, is the history relevant? History is not always relevant, right? But is it relevant in this case? Is the history relevant?
Yes.
Okay, why? Okay, why is the history relevant to us?
Based on the fact that the dad had colon cancer and died at age 40, and the younger sister had endometrial cancer. So it's not just colon cancer alone. So yeah.
Okay, so when it comes to family history, right? First degree relative. That's one thing I want to always think about. One of the first reasons why this history is important to us is because they are first degree relatives. If I'm telling you that it is a cousin, it is a paternal grandfather, mother, things like that, some random relative somewhere, it's not as strong as what a first degree relative. So first degree relative family histories, very important to us, right? Secondly, the reason it's important is because the patient is young. Patient is 38 years old. When do we normally say colon, although the incidence of colon cancer is higher in younger people now, but even still, when cancers are typically, except with some exceptions, are mostly disease of older patients, right? So 38-year-old having colon cancer, around the same time the father died, it is important to us, very important. So we're going to start thinking, well, this is likely hereditary, right? Colon cancer and not spontaneous, sporadic rather, right? Hereditary. Okay, so that's important. Now, the location is what? Right-sided colon cancer. If I'm thinking hereditary, there are two hereditary types of colon cancers that you must know, causes, high yield. Number one will be what? HMPCC, and number two is going to be FAP. These two you must know. Even if you don't know the other hereditary causes, these two everybody must know. Now, my question is, how do you tell them apart? Based on this vignette, how do you differentiate between HMPCC, FAP? So you have to tell us which one you think the patient has, HMPCC or FAP, and tell us why. Who wants to try? Is it HMPCC or FAP we're dealing with here, and why? Okay, based on family history. That's one point. What's the second point? Okay, no, Kubab, not the answer. Is this HMPCC or FAP from the vignette alone? Does the patient have HMPCC? Does the patient have FAP? OG says HMPCC based on family history, but FAP also have family history of colon cancer. FAP also has family history of colon cancer. So family history alone is not enough. What else? What about the family history? What about the vignette? Tells me it's definitely this or that. Endometrial cancer, very good. So it's not just the family history. There will be family history of colon cancer in both FAP and HMPCC, but the family history of endometrial cancer points more to HMPCC. FAP is not associated with what? With endometrial cancer. for HNPCC is. That's number one. Number two, the location of the cancer. HNPCC is what? Right-sided. It usually affects the right side. Right colon. FAP usually affects what? The left side. Number three is what? Polyps. No polyps. HNPCC stands for what? Hereditary non-polyposis. FAP stands for familial adenomatous polyposis. So in HNPCC, there are usually no polyps. The cancers are not preceded by polyps. So number one here, the family of endometrial cancer is shown with HNPCC. The location is right side, not the left. And finally, there are no polyps. So those things support what? HNPCC over what? FAP. And if this is HNPCC, what gene is mutated? HNPCC, which gene is mutated? It is going to be MSH. And what does MSH do? Final question. What does MSH do? Normally do. MSH normally does, right, DNA mismatch repair. Excellent. DNA mismatch repair. So it's a tumor suppressor gene, right? So if it's mutated, mutations will accumulate, right? And that can lead to HNPCC. All right. So this is the level of attention I want you to pay to your questions. When you have conditions that look similar, make sure you can list several things that can help you tell them apart. You may be given all of those things, you may be given two or one, but you still be able to consistently and confidently tell them apart and still be able to differentiate them and get your answers correctly without being confused. Thank you so much, guys. Sorry for going over the 1 hour. So we're gonna stop here. I hope you're able to learn one or two things today, even if it's one thing. If you have any further question concerning what we discussed today, concerning your preparation, please, you can send it to the WhatsApp group. If you don't want to send it to the group, if it's more personal, send it to Essential number, right? Essential Tutor's number on the group, and we'll reply, right, as soon as possible. And we have a feedback form as well. You can give us feedback about your experience for the first week as well as this tutorial session. Tell us how we can make it better, make the experience better for you for the next 2 weeks, and we'll be happy to oblige. Thank you so much for your patience. Have a wonderful weekend and enjoy the rest of your day. Bye.